This morning, for about 90 minutes, we're going to have two sessions. The first on risk communication till about 9:30, and then a short session, a very short session on crisis management and crisis communications. And I have a presentation of for both subjects, and there are print versions of this which you can pick up at the end of the session. And of course, the presentations will be loaded up on the website. However, I'm going to see if we can do it without presentations and do it with talking together. So my first question is, what is risk? So somebody tell me what they think. A definition of risk. Let's have a definition from Saudi Arabia. What is risk?
I didn't know specific definition.
Sorry?
I didn't know specific definition.
Do you take risks in your life?
Yes.
What kind of risks? Not the personal ones. Some you can talk about in public.
During my car, maybe no stopping at red light.
Okay, there's a risk. Okay, and what is the risk there? What is the possibility? He drives his car and may not stop at a red light. He is taking a risk, yes. What is the risk? What could happen?
Maybe have an accident.
Maybe you have an accident, yes. Generally speaking, when you are driving, how do you try to manage the risks of driving?
I don't know.
Okay, let's see if somebody else. When you're driving, how do you manage the risks of driving?
You make sure you follow the road signs. You read the road signs.
You read the road signs.
Yes. And the traffic regulations too, you go by them.
And you stick to the traffic regulations. Anything else? Can you think of some other things you do to manage risk when you're driving?
There is a suggestion there behind.
What's that?
Will has a suggestion.
Okay, well, you tell me. But what do you do?
Well, I also follow the traffic signs, and I don't know. I have a license to drive.
You have a license to drive.
So.
Did you train? Did you do some training to drive?
Yes.
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 So that's one way of reducing risk,
reducing
isn't it? Yeah. Okay. Well, do you have something?
Also by anticipating on potential things that could happen.
Oh, now there's a clever one. Anticipating potential risks, things that could happen. Yes. Okay, so that's a simple example of everyday risk taking, risk management, and also risk assessment. We can go through it, can't we? Driving is a very risky business. A lot of people die on the roads, and a lot of people have accidents. And there are ways in which you can assess that risk. How much risk is there? And how can you manage the risk? How can you reduce it? Or you can't actually get rid of it entirely. And things that you can do to also increase the risk. What is one way of hugely, massively increasing your risk of having an accident when you're driving? Oh, drink certainly. What else? Texting and using your mobile phone. I think that the statistics in different countries are different, but the minute you look at your mobile phone, you listen to your mobile phone, or you use it, you are increasing your risk of an accident by an enormous amount, huge amount. And some literature says doubling your risk of an accident or of dying on the roads. Okay, so those are the risks in everyday life, and we all have taking risks all the time. We're assessing risks, managing risks, and anticipating risks, and by doing that, managing them at the same time. So, what are the risks that patients face? As soon as somebody has a symptom or is sick and goes to an engagement with healthcare, what are all the different kinds of risks that situation then presents to them.
So missed your question. I don't understand.
Okay, that's fine. Now, do you remember communications repetition? Yes, he's an attentive, intelligent man who's only just waking up, of course, but he missed the first time, and that's not because he's stupid, because we do. Yes, we miss things. So repetition is a very important part of effective communication. What are the risks? What are some of the risks that a patient faces as soon as they engage with the healthcare system, or as soon as they have symptoms, in fact, but particularly once they engage with the healthcare system?
The drugs.
Okay, what are the risks of drugs?
The medication errors, and also the wrong prescription.
Wrong prescription.
And the wrong diagnosis from the doctor.
Wrong diagnosis. And ADRs.
Yeah.
Well, I mean, those are the obvious, aren't they? Those, yes, that's exactly right. What other risks are there for a patient at this time which are not specific to the drugs? Any thoughts? Justin, put this close to your mouth, please.
Sometimes wrong dose.
Okay, it could be the wrong dose, but can you also think of some that are not specific to the drugs? Ethel.
Like the medical devices.
Okay, oh yes, certainly. Device is not working properly. Yes, Java.
Maybe unnecessary lab tests or x-rays, or being in front with invasive methods doesn't need that to make a diagnosis. It's a risk.
Very good. This is a very interesting topic, and we can't spend much time on this, but I would love to. Do you know about the risks of, for example, the risks of screening for breast cancer? That one of the risks, everybody, customarily, traditionally, people have said that screening for breast cancer is a wonderful, helpful thing that saves lives. Increasingly, this is a controversial view, because one of the things that happens when screening for breast cancer is that you get false positives, a very large number of false positives, or uncertain results. And a lot of the women who have false positives or uncertain results then go on to either a series of very unpleasant tests or even surgery, even mastectomy, when there is an uncertain diagnosis. And so the risk of screening is much greater than people realize, and it's a risk you would hardly expect from what seems like a simple and safe process. So yes, I mean, the risks of all sorts of unpleasant things happening which aren't relevant to the case. Then, of course, you've got the risk of the disease itself. What are the risks of the disease? And what are the risks of no treatment? And what are the risks of the different kinds of treatment? So, do you begin to see now that when we are communicating with patients about risk, we're talking about a very complex range of different things. The ability to do that effectively so patients can make informed choices is a big challenge for doctors. And for us to some extent, of course, because we are talking about the risks of individual drugs, and we need to convey that information to patients. Okay, another question now. In a room like this, or in a community, or in society, what is the range of attitudes to risk? How do people differ in the way they think about risk or feel about risk? Do most people feel the same, or do people have different ideas about risk? In their own lives, or in medicine, or in anything at all?
It's mainly depending on your culture, where you come from. Maybe it's normal for me to hear a shoot gun in the air. It's not a risk for me because somebody's wedding or somebody's celebrating something, he will shoot some guns in the air. But in Sweden, maybe you will be terrified hearing such a thing. I don't know what is. So mainly it depends on your culture on that. Depends on that.
Okay, I mean, that's a very important point. Culture does have an influence on how we feel about risk. And in some cultures, you'll be so used to danger that your tolerance of risk will actually be much higher.
Not. I think it's also a matter of chance. And what he knows is that when he in his country hears a gunshot, it could be due to some fighting, or it could due to the fist they're firing.
Indeed. What about individual reactions and feelings to risk? For example, if you have teenage children, particularly teenage children or younger children, do you think they have the same attitude to risk as you have? Why?
I think attitude to risk depends on the person itself. For example, with drugs, depends if it's a healthy patient, a healthy person, or a sick person. It depends on what is the risk. If it's on the drugs, so they have different attitudes towards accepting it. Now, between young people who are more prone to take the risk, the attitude would be different from parents who would be more careful in assessing the risk.
Do you agree? Is that right? I mean, I think she is right. What about the difference between adults, not just between adults and children, but the difference between adults? What range of different attitudes do you think there are towards risk amongst the adult population in any country or in any community or across the world?
My thinking is that males take more risk than the females.
Oh! Now there's that's a controversial. He says he thinks men are more likely to take risks than women. Do you think getting pregnant is more risky than anything men do? And I'm not sure about that. We could have an argument about that. My goodness. But the truth is, of course, that people's attitudes to risk differs enormously. That some people are risk averse. They avoid risk. They want to manage risk to the minimum possible amount, don't they? Whereas other people on the whole spectrum are much more risk-taking and adventurous. I mean, rock climbers, astronauts, racing car drivers, all these kinds. These are very obvious examples of high-risk activities. So what is the implication of this then when we're talking about providing information about drugs to patients? How does this knowledge of the variety of people's feeling about risk, how should it influence our communication of risk about drugs? Thank you, Joe. I'm going to have to force other people to speak. There are too many who are modestly staying quiet this morning.
Maybe the most important thing for one is to know about there is a risk, to raise his awareness, the knowledge of the thing, take an example, the baby. He doesn't know that the fire may do harm to him, but when he touches the teapot or something hot, he will, by trial, he will recognize this is something I shouldn't touch. So the first thing is giving the knowledge. This medication could do this and that.
That's a very, very, very interesting and important point. Of course, I fully agree with that. I think for the patient, he has to calculate two different risks. When I'm not taking a risk, what are my chances? And when I'm taking the risk, what are my chances then?
So he's saying the risk of the patient is two things. What happens if I don't take the drug, and what happens if I do take the drug? And what Jabba was saying about learning that there is risk is also something very important for us, because I think it is still commonly believed that medicine is safe. I mean, most people are surprised when you tell them that medicines do have risks. I think is that true? I think many audiences, I think, still expect drugs to be safe. And we've done 1 or 2 sessions with journalists, I think I told you about this, trying to encourage them to have a better understanding of drugs. And they are sometimes astonished to hear, that penicillin can kill people, and that sort of knowledge is not common. And the trouble is, isn't it, I mean, the point you're making is absolutely right. If somebody does not know there is a risk, then they will not be able to assess the risk, they won't be able to manage it, and they are themselves at risk. And the other point is that if something bad happens and people don't expect anything bad to happen or think it can't happen, they will be very upset. Indeed, maybe angry enough to take you to court and cause a great deal of trouble. So this background knowledge that there is risk, I think, is a very important one. Okay, so calculating risk. Oh, all right. Any thoughts about that so far? It is a very complex issue. Yes, Ali. Can I switch this on? Yes.
Also, there is, if, for example, a patient is to take certain procedure or test, they will calculate what are the benefits to this procedure. Because most likely, if the procedure may likely to lead to another problem.
Indeed.
They'll have to think twice.
Very good point. Is this procedure simple, or can it in itself lead to another problem? And I've got an example which I'll show you. That's a very interesting point indeed. I think something else we just perhaps need to talk about before we go on to my examples is this question of the nature of risk and the nature of benefit. Because when you're talking about managing risk, you're also constantly thinking about what is the opposite effect, the benefit. And benefit, like risk, is entirely different for different people. And I'd like you just to think about that for a moment. If you think about the benefit of a drug which is going to deal with a disease, what are the different kinds of benefits that different kinds of patients might hope for with the same drug, maybe in the same disease and the same drug, but looking for a different balance or a different kind of benefit? Would you like to have a shot? Okay, this is a great lesson for us teachers. You are a serious student, you are making notes, trying to keep up, and you can't make notes and process everything and listen to questions. So you do not have to be embarrassed about asking for the question.
Yes,
the question
I'm
is,
sorry.
no, it's absolutely right, but it's important to notice this, isn't it? Because if you just steam on, she'll not hear. The question was this. Different patients have different attitudes towards risk, but they also have different attitudes towards benefit. And what might be some of the different attitudes to benefit that patients could have?
Different patients have different individual and unique.
That's absolutely true. They're all individual and unique. And can you tell us what might be some of the differences between two patients with the same disease and the same medication, but looking for a different kind of benefit? Or a different emphasis of benefit, a different priority of benefit?
I think about the emergency for treating.
The
emergency for treating for those patients.
Yes.
Yes. It could be considered based on the individual of the patients.
Yes. Any example? Can you give us an example? Anyone have an idea of an example? Yes. Oh, please, no, here. Thank you very much. That's great. Do not be embarrassed.
It will depend on the stage of the disease. For instance, if I have a discapacity or I'm unable to walk, for instance, for me it would be very important that that drug will benefit me from that standpoint. As whereas if I have, for instance, I don't know, probably movement in my hands or numbness in my hands, that would be something important for me. It depends on the stage of the disease.
Very good. Yes, I mean that's absolutely right. Very important. First, the stage of the disease, which somebody has mentioned. I think that's another issue we've come to understand. That at the extreme end, terminally ill people may want the benefit of relief from pain, and they may want quality of life now. That is one benefit, even if the risk of that particular approach to their care means that their life will be shortened. There are other patients who will want their life prolonged. They'll be more interested in quantity than quality, for example. That's an extreme idea. Marie Lindqvist, when she has talked about this, uses a lovely example, which is that of a pianist with some kind of rheumatoid problem in her body. And what the doctor didn't realize for her was that she was not concerned about the relief of pain. She was concerned about having the flexibility and movement of her fingers protected. That was her top priority, so that she could continue to play the piano. She was prepared to put up with a lot of pain if a medication could be found to give her a degree of flexibility in her fingers. So I think that's a rather beautiful example. The same with a dancer, for example. You know, that a medication that helps somebody to continue doing that may be very important for them. But different patients will have different ideas, and pain management and tolerance of pain may be an important element in a patient's assessment of the risk and the benefits that they are looking for. For some people, pain management will be the #1 priority against everything else, even if that brings with it some other risks. So, again, we talk about the risks of a particular drug, but that's within the context of this whole complex interaction of attitudes to risks, different kinds of risks, and different benefits. So I'd just give you take you through some of this material I have, because I think we've done all this, risk of what is baby. This is an interesting, very interesting question about risk. And it was a study in the UK of the risk to your baby of a woman having her baby at home or in a midwife-led unit or in a hospital with an obstetric and gynecological ward nearby. And I would like to spend a lot of time with you on this. And of course, the whole business about the risk of birth is a very important international question. So these are the statistics and the discussions about the research, and you'll find this on the printout and on the website. And if we were doing this for a whole day, as we could be, I'd look into this. So you can see there are four different places where women will be given birth. At home, in a freestanding midwife-led unit, in a midwife-led unit alongside a hospital obstetric unit, or in a consultant-led hospital obstetric unit. And the outcome of this is utterly fascinating in all sorts of ways. I wish we could spend more time on it. But if we have some results which help us to advise women about the risks, not to tell them what to do, but to advise them what the risks are. So the risk information of this from this research was that overall negative outcomes for mother or baby were about 4.3 births in 1,000 across all those settings. For first-time pregnancies, technically known as nulliparous, you know that, the risk at home was 9.3 in 1,000 for a negative outcome. So a first-time mother having her baby at home, even with a midwife in attendance, the risk was higher than it was for the average and higher than in other settings. But for women who are having their second or third or fourth child, there was no difference across settings at all. So the only issue I want to look at here, rather than discuss all the other interesting aspects of this, are the two figures. Do you see the overall negative outcomes, 4.3 births in 1,000? That's the population figure. But for first-time pregnancies at home, 9.3 per thousand, there were negative outcomes for the baby or for the mother. Excuse me. So, will you please tell me now, how do you express that risk to a mother who is first-time mother, who is saying to her nurse or doctor or anybody indeed, what is the risk? What should I do? How would you express what we've learned from this research to her in order for her to assess her risk of having her baby at home or somewhere else? How would you just speak it? What's the language you'd use to, given 4.3 and 9.3? How would you express that? Say to her, okay, well, if you have your baby at home, something, 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 what would you say? Have a go.
Maybe that you can have a high risk of that. I don't know, that something can happen with you during the delivery.
Okay, that's a good start. Please go on.
Yeah. But of course, it's difficult to convince her to decide that maybe if she wants to do it at home. So of course, it's these numbers. Maybe it's not so big difference. 4.3, 9.3
Okay.
for her. It's her. I think that it would be difficult to convince her because not enough high differences. I think for the first. For the woman who is first-time pregnancy, because for the second, so she knows what happened, what will happen.
Yes.
So this is the difference. And the first time you don't know exactly what will happen.
That's absolutely right. And of course, you're right to say that there is a higher risk. I mean, there is a higher risk. There's no question about that. But how would you express that higher risk? And so you say, well, if I was a pregnant mother, you'd say, well, the risk is higher if you have your first baby at home. And I say to you, how much higher? What do you say?
Okay, twice time.
Ah, yes, yes. Twice the risk. I mean, that's one way of expressing it, isn't it? Yes?
Yeah.
A doubled risk.
Yeah.
Yes?
Double risk, okay.
What? All right. Now, would any of you like to comment on that? If the mother didn't have the figures 4.3 and 9.3, and someone says to her, the risk of your having your baby at home is double. The risk of a damage to your baby is doubled if you have it at home. What is that message conveying? What is that message? What direction is that pushing her in?
Okay, with regards to the example, I would tell her there's twice the risk of developing a negative outcome if you have your baby at home,
yes,
as opposed to having it in a hospital setting.
Right. Okay. But would somebody comment on the language? Close to your mouth.
I think I agree with what you said, but I also would add that the overall risk is very low.
Good. Okay. I don't know if you're beginning to see how important this is. Where is this? I have a slide here. Yes, here we are. The headline in one of the newspapers in Britain at this time was that triple the risk of death or brain damage if you have your first baby at home. Now, 3 times is a bit an exaggeration, but they could say double the risk. If it said double the risk, it would be accurate. But what is the impact of this? Double the risk of death or brain damage to... it's over-dramatizing it, isn't it? Because the point that you have made is the absolutely perfect one, that the actual risk in terms of numbers is very low. Now, these are 2 concepts which I don't know, I'm sure you are familiar with. What kind of risk communication do we call when you use the word double or triple or whatever, that kind of thing? What sort of risk statistic is that? What's the name of that kind of risk statistic? Do you know that? Yes. Put this close to your mouth, please.
Relative risk.
Very good. And what's the other kind?
absolute.
Yes, and what? Tell me the difference. Relative risk and absolute risk.
If we come to the relative risk, is the comparison between both groups.
Yes.
The absolute risk is that is the number of the occurrence over the overall population.
But yes, I mean the absolute risk is essentially a statement of the figures. So this is something you need to think about in your crisis communications, which we'll come to, but in all your communications, that very often people will use relative risk, which is expressing the risk in terms of the relation between the two outcomes. That if we go back to the figures, the 4.3 relative risk is doubling from 4.3 to 9.3. People say the risk doubles, okay, and that sounds very dramatic and terrible. But unless you have the absolute figures, the absolute risk, you can't make sense of relative risk at all. Because yes, the risk doubles, but the figures are very small. 4.3 to 9.3. And you're quite right in saying different women will assess that absolute risk in different ways. Some will say, well, I'm not prepared to take even that small extra risk. But some will say, well, I don't think that's a very big risk. And I have good reasons for doing it. So if you see expressions of relative risk anywhere, and there are no absolute figures, the chances are somebody is trying to deceive you by making you think the risk is greater or the benefit is greater. Doubles your risk of avoiding doubles your chance of avoiding a heart attack. And that from what? It may be from 1 in 10,000 to 2 in 10,000. That's a doubling. But the figures are almost invisible. So in talking about risk communication, this is perhaps the single most important thing. And it is also the issue which gives rise to the greatest controversies in societies. Because often you get headlines like the one I've just shown you, where they say a drug triples the risk or doubles the risk or a procedure or a whatever it might be. But unless you have the figures, the absolute figures, what you're looking at is something that is a deceptive story. So absolute risk, relative risk absolutely essential. And this is, I can't go into this this is maternal benefits of having your babies at home. And a lot of women feel very strongly about these. And they will weigh those against the risk to their babies when they believe there are very important benefits. And the actual benefits are remarkable too. And these have to be included. Now this is an interesting one, and I will talk briefly about this. And this comes back to what Jabba was saying, that here you have a considerable risk of disease, yes? Colorectal cancer is a killer. And you do have tests, colonoscopies particularly. And the figures, and it's very interesting too, because you have to make a decision as to whether or not you want a colonoscopy or whether you'll just wait and see if you get it. And because I'm a man over 60 and a British citizen, the health service tries to persuade me to have a colonoscopy. And therefore, you have to look at the risks of the disease, of the intervention, of no intervention, and all the rest of it. And I'm not going to tell you a lot about this, but other than to say it's a significant risk communication issue. They sent me a very good leaflet explaining all this, about how many people will develop bowel cancer, about the age profile of colorectal cancer victims, how many die, as you can see, and regular screening reduces the risk of dying by 15%. Okay, what does that mean? That's a relative risk, isn't it? It doesn't tell me what the 15% is. How many So that left me a little bit. Colonoscopy screening. Now, this is very interesting too, because it makes the whole risk communication about this procedure even more complicated. 5 out of 10 have a normal result, 4 out of 10 will have a polyp, and a benign polyp, 1 out of 10 will have cancer. But now look at the risks of the procedure. Complications like heavy bleeding, 1 in 150. Damage from procedure like a hole in the bowel wall, 1 in 1,500. And death, this is from a screening process, 1 in 10,000, which the National Health Service in Britain calls extremely rare. Now here we have another very interesting and important issue. We use these terms, common, very common, uncommon, very uncommon, or rare. And will you tell me about what you think about the use of language like that? What's the problem with using language like that to say to somebody, this ADR is rare, or this is quite common, or not very common?
By communication, by that, you are pushing the patient in some direction.
Certainly, if you're talking about death, you're colouring, aren't you, the whole range, the whole communication, because it then looks as though the procedure is not safe. But what about the use? Go on.
Yeah, but what I was talking, when you're colouring, you're pushing the thinking of in one direction or another direction.
Very good. This is okay. That's a very important issue. He's saying that the choice of communication and language that you make can push somebody in one direction or another. And in technical terms, this is called framing. It's the way in which you frame your communication, either emphasizing the benefits or emphasizing the risks. So if a doctor says to you, 990 people in 1,000 have no trouble with this drug, that's presenting the benefit. 990 have no trouble, but 10 people do. Okay, now if you don't mention the 10 who have a trouble, 10 in 1,000, you are biasing the information you're presenting by putting the positive first, or only the positive. So that's one very important issue. So the framing of your communication has to be balanced if patients are to be able to make a true free choice. But what about the word common? For example, let's look at this. All of us could go for a colonoscopy. What is your view that 1 in 10,000 deaths from a colonoscopy is rare, extremely rare? Do you agree with that? Do you think that means 1 in 10,000 is extremely rare? What do you think, Shota?
Maybe it depends statistic.
Now, what do you think? What do you feel? You're too young for colonoscopies yet, but if you were over 60, what would you think about this? Do you think 1 in 10,000 is extremely rare?
Maybe.
No, what do you feel? All right, I am going to give you. I'll give you $100,000. But 1 in 10,000 of these gifts will kill you. This is 1 in 10. Here's $100,000. Okay.
Yes.
I will give you this, but 1 in 10,000 times these dollars will kill you.
So it's rare.
Do you think it's rare?
No.
It doesn't feel rare then, does it? Do you agree with him? Tell me about what you think. Excuse me.
Because I think this number is still low. Because 1 in 10,000, I think risk is very near from me. So
okay,
it's not far from me.
Also. Oh, I see. You think there is a. This is not. This is very. You see how difficult to express this. Would you think it's dangerous?
Yeah, I think that.
Okay, that's very interesting, isn't it? Okay, so the point is made, isn't it, that different people have a different understanding of what these words that we use, and you get in all the leaflets about common and not common or rare and so on, that patients will feel differently about those things. And I actually happen to feel like you, that I think death from a colonoscopy in 1 in 10,000 is a bit worrying. Because it may be 1 in 10,000, but it might be you. You might be the one. So this is difficult stuff, isn't it? And you think about trying to write a patient information leaflet, which includes information about the risks of drugs and so on. It becomes more and more difficult. I'll tell you my decision about my own colonoscopy screening at the end. Now we need to move. This is all. You have all of this on the printout. Don't have to worry about this. This is the full story of each of these issues. So I want to get on a little bit in the last few minutes to how we present risk information, and this is I think the beginning of quite an interesting way of graphically presenting risk information. You know, don't you, that I am very keen on pictures and graphics and trying to reduce the number of words that we use in everything. And I'm going to show you a number of ways in which you can communicate risk statistics graphically rather than in words, and I think are much, much more reliable. But as with all communication, we need to be trying to use lots of different ways, because different people, different patients will react differently to different presentations of information. Some people will like the words, some people will like the pictures, some people will like other methods. So this is just a kind of general way, a relatively small number of words and a fairly dramatic sort of picture, like our Michael David, you remember the fat man at the beginning of the session. This is street communication of risk, I think, which is also rather important to think about. And when I think of Gulbara's, where is she? Where are you, Gulbara? Oh my God, she's gone. In Kyrgyzstan, she was telling us that they are making short video films, which they're going to show in all the cinemas in the country, you know, during the advertisements, very short film shorts. Street art and popular locations for communication are probably very important. Now, this is a specific example of a commonly used drug. You know this, I'm sure, steroid. And we can't spend any time talking about the detail, but this is the risk profile of prednisolone. This is the first thing. This is about psychiatric problems with the drug. This is the contraindications, and this is side effects of the drug with unknown risk. It says, and this is 2014. Look at not only unknown risk, but look at the list and the second page of unknown risks. Okay, this is about 100 or more. So I have to ask you, as patient safety experts and pharmacovigilance persons, what on earth do we do with this amount of information? I mean, I don't think there's any point in telling patients about this if you don't want to frighten them. It's simply astonishing, because there's virtually everything. There's almost every disease known to man and woman in this list. So how do we just give me an idea of how we deal with this? How do you decide what risk you are going to communicate to patients for a simple, everyday, common drug? Well, it's not a simple drug, but an ordinary, everyday drug like that. What do we do with so much information for the patients? Any thoughts? No? No thoughts. Oh, come on, you have to start somewhere. Okay, good.
I believe you should start by stratifying the risk.
Stratifying?
Yeah, which is the most important, which will be produce more damage for that patient according to the disease. And of course, that would be the scoring for your communication, which is the main focus of that communication.
Very good. That seems to me an extraordinarily useful comment. I need to ask you a question, though. With a drug like this, where you say there are possibly 100 side effects, which with unknown statistical risk, you don't know what the frequency or the incidence is. How would you start to do that stratification?
By the seriousness.
By the seriousness. Yeah. Okay, very good. And would you would also leave some out, wouldn't you? You'd have to leave some out. Yes. I mean, what she's saying is absolutely right, of course, isn't it? That you need to start by stratifying the risk in some intelligent way, which makes sense for the patient. So the most serious and the most worrying and the most damaging are clear and at the top. And second, of course, that would be assessing the risk, and then managing the risk, of course, is communicating ways in which you can recognize the early signs of a serious effect, isn't it? That's the next bit. That's the managing the risk bit. Communicating the risk is, say, you may have severe headaches, maybe not a serious one, but serious headaches can mean something much worse. And as soon as you have a headache like this, come and see me again, or whatever it is. I mean, but according to the individual patient. But this is not an easy task, and I feel foolish trying to deal with it in 2.5 minutes. But I want to draw your attention to it and see that you have to make decisions about this as regulators, as pharmaceutical companies, in your communications with the public. And you have to make decisions too. Now, this is an interesting case, Depo-Provera. I'm not unfortunately going to go into it at all, but there is a doubling of the risk of breast cancer in women who take quarterly injections of Depo-Provera. Doubling of the risk. From 1 in 230, now somebody should have said to me, but what are the numbers? It's from 1 in 233 over a year to 2 in 233 over a year, okay? So, I'm not going to do that either. This, I just want to show you very briefly, is the result of the use of something called a decision aid for patients who are making complex risk decisions. There are some extremely good tools which you can find on the web which allow a patient either electronically or on paper or in discussion with their doctor to work through all the risk issues about a drug or a procedure and to come to and to rate different benefits and harms and hopes so that they can come to some kind of decision. And this is the result of a woman's assessment of her decision for, as you can see, options for breast and ovarian cancer screening on risk-reducing mastectomy, whether or not she wished to have a mastectomy as a preventive measure for breast cancer. And so she rates different elements of her feeling, and then at the end, in this particular case, she was still undecided. It didn't allow her to make a decision because it was so complicated. But decision aids as practical ways, ticking boxes and accumulating your own scored priorities, are very, very impressive ways of helping patients make very much individualized decisions. So I show you this again, the usual conventional, traditional patient information leaflet, rubbish, waste of time, outrageous, etc. Java, yes.
Bruce, you are confusing me now.
Ah, I'm sorry. Well, thank you for telling me.
It's a personal thing. Now we are going in our countries for a campaign for early detection for breast cancer, and all this mass media, you have to go, you have to go, you have to go. Where do I spot that from the risk benefit now? We are not talking about maybe these campaigns would totally hide the risk and just magnify the benefits when you do such a campaign which is supported by the government. And maybe all of us, we've heard about the actor who removed her breasts for the risk of developing breast cancer. Maybe it's
Angelina Jolie.
Yes. So there is a worldwide media about doing that, and still we are not focusing on the risk. We are going through the current and about only magnifying the benefits.
Okay, I can't act as your consultant on breast cancer screening in Saudi Arabia, in Jordan. But I can only say this, that I've done a lot of reading about this recently, and it seems to me in the West, you'll have to confirm if I'm right about this, in the West there is more and more skepticism about the benefits of breast cancer screening. The number of lives saved versus the number of women who have to be screened appears to be almost invisible. And the harm, and this is what people have been looking at much more, the harm caused by false positives and the psychological harm caused by the whole process appears, in the judgment of many scientists, to be far greater than the benefits. And that the benefits are extremely small for an immense amount of expense. So you'll have to read all this stuff. And my feeling is that your government is behind the international evidence and discussion on this. It is a controversial matter. But the whole business about screening is the same with prostate cancer screening. That there is very little evidence that it it reduces morbidity and mortality particularly, because a lot of the benefits of these things are judged on, for example, 5-year survival. They're not judged on mortality statistics. And if you don't judge them on mortality statistics, you have no basis on which to say that screening has saved those lives, because they may have died at the same time as everybody else who wasn't screened, unless you have endpoints. Surrogate endpoints are really not very successful. Anyway, so you need to be confused, and I think you need to be quite concerned about the integrity of the risk information that you're giving your people, in the light of a lot of new discussion about this. Or certainly, the other aspect of risk communication, the degree of uncertainty about so many things. That often when we're talking to patients, we have to say, as far as we know, this is the best information we have. It might change. So we also have to, first of all, make sure that patients understand there is some risk, which again is quite a thing to do. And then we have to say, but we may not be sure what the risk is. And again, maintaining trust with patients when you are both saying, what I'm doing to you can be dangerous, but I don't know exactly how dangerous, requires, again, a lot of skill. So this is our principal kind of risk communication, as you know, with patients and with doctors too. So some other options, things like the Swedish patient FAS, which has is now electronic only, I think, Anders. I'm not quite sure. Is it still in print or not? But this is a wonderful, amazing publication which 80,000 people used to buy in Sweden, which has the risk information about all the drugs on the market in Sweden and is now on the web, I think. There are good information leaflets by people like the American Council on Science and Health. And this is one of the tools that it's possible to use in communicating risk of a particular drug to anyone. If we go back to the pregnancy thing, do you remember we would say that about 4 in 1,000 women here will have a negative experience of childbirth, a delivery at home. Across the population, about 4 women will have a negative experience of childbirth. If you have your first baby at home, it will go up to 8. And I thought I had an animated 8 coming in there, but I don't have. But do you see how this, in terms of framing, it shows you exactly the situation. It shows you the number who are harmed and the number who are not, in a way that is much, much clearer than using words. These ones at the bottom are just different risks. You see this one here is the odds of a woman having a miscarriage as a result of amniocentesis, 4 out of 1,000. And here's the odds for a 39-year-old woman of producing a child with Down syndrome or other chromosomal abnormality, 12 in 1,000. So that this gives you a picture of the risk, exactly, literally, which I think is in many ways much, much better than words. Not for everybody, but for some people. And these you can find on the web as well, of course. This is an interesting presentation of, here it says, what are your odds? Rather disturbing, very disturbing figures about arrests in New Zealand. And you can see the first one there. If you're white and Caucasian, what's the like of your being apprehended in relation to a homicide? As a white Caucasian, almost 0, and as a Maori, almost 100%. I mean, the staggering kinds of, and a very vivid way of presenting particular statistics. Here are these. One on the left, the one on the left you can see is families, is 1,000 people as parents and children, and this one is, what is this one? I'm not sure what this is. Oh, this is mixed. That's probably all men, isn't it? Yes, I think so. So you can have palettes like this which are suitable for a particular patient or a patient group. This is a beautiful video animation of risk, which I won't show you now, but it is enough. You can go to it when you have the reference about the risks of adjuvant radiotherapy after surgery for cervical cancer. And it's a beautiful animation, which I think I certainly like very much indeed. Other ways, all this stuff, email and alerts, getting information to people. We'll leave that. But here is the real challenge. At this point, how do you communicate to a patient about the risk of their disease and the risk of their drug? And we've started to talk about some of the techniques and some of the complexities of that. And if a patient comes into you and says, I hear the risk of deep venous thrombosis is doubled if I take hormone replacement therapy, you need to be in a position, or pharmacists and doctors need to be in a position to say, yes, it's doubled, but it goes from 15 in 10,000 to 30 in 10,000. Is that a risk too great for you to take, and so on. So here, everything we think about is what can we do at this point with the patient to make sure that what we're telling them helps them to make a good decision. Every patient is different. We've talked about this. Risk perception, we've not talked a lot about that, but everybody's perception of risk is different. Communication of risk, all those issues we've covered. This is another interesting one, a case study which we can't really go into. The risk profile of paracetamol, which everybody thinks is really rather simple, common, everyday drug, don't they? But, of course, has huge risks in interaction with other drugs, in overdose, and so on. Yes, relative benefit. If we talk about pharmaceutical company advertising, they will probably say doubles your chance of a long life or something of that, those kinds of relative risk claims. And remind you that pharmaceutical companies do communicate very beautifully and effectively, and that we are in competition with them for our balanced scientific risk communication. So how do we get to this one person in the crowd, the perfectly tailored risk communication? So colorectal cancer and irrational me, there you are. This is my outcome on my personal decision. I've made no decision, to tell you the truth. Last year, my younger brother died of colorectal cancer, so I have a very particularly personal view of it as as a disease, and in some respects I'm less frightened of the disease than I am of what I saw him going through in treatment, which in some ways was so dreadful I think I'd rather die. And that's a nice personal idiosyncratic response to a potential risk, for example. So I think I fear I fear having a colostomy bag and chemotherapy and liver failure and all this. I fear all that more than I do just having cancer and dying, which I think might be a better that's for me. So I'm just saying my doctor would have to understand that my view of the risks would not be the same as his, or my surgeon. Totally different. And this last thing, if I could die in the screening process, before I even knew if I had cancer with a colonoscopy, 1 in 10,000, if I could die then as well, do I want to start all that going? Do I want to start that at all? So, I think we have covered that. Yes, and so this will give you the kind of textbook chapter for you to take and study all the stuff we've talked about today, the many details that I've skipped over. And that's the end of that.